Hello, good evening everyone, and thank you so much for joining tonight's first live Marrow 101 webinar as part of BMDP's Virtual Match for Life 2020. My name is Marc Hickman. I'm a BMDP Ambassador and I'll be your host for tonight. I first got to know and became involved with BMDP in 2016 after a friend sadly passed away from leukemia. Since then, I've tried to do what I can to help raise awareness and donations for this important organisation through annual memorial football tournaments in honour of my friend, also through my football team, CBD Wanderers, where we would proudly wear the BMDP logo on our jerseys, and also through work drives. In tonight's webinar, we'll be talking about blood diseases. Blood diseases like leukemia and lymphoma are in the top 10 most frequent cancer deaths in Singapore. However, there is a lack of understanding when it comes to blood diseases. It can range from non-life-threatening, like G6PD, to severe, like leukemia. Doctors who study and treat blood diseases are known as haematologists. In this session, we have invited two haematologists from the National University Hospital who will be sharing their personal experience of treating patients' blood diseases. If any members of the audience have any questions throughout tonight, please use the Q&A feature on Zoom and we'll reply either through the live questions at the end of the sharing or reply using the Q&A feature. So I'm now delighted to introduce Dr. Poon, a senior consultant in the Department of Haematology Oncology, and Dr. Yeap, a consultant paediatrician in pediatric haematology and oncology. Dr. Yeap, maybe if I can just start with you, if you can just share with the audience a little bit more on your background. Or if you can just go off mute, Dr. Yeap.
Hi. I'm really glad to be here tonight to be able to share a little bit about what I do. So everyone calls me Dr. Frances because they're all children. So I actually graduated from the UK and I've been practicing in NUH for more than 10 years now. I'm a pediatrician, but I'm also a pediatric oncologist and a transplant physician. I particularly have an interest in cellular therapies for children, and especially in the non-malignant conditions and immunodeficiencies.
Thank you, Dr. Frances. I'll call you Dr. Frances as well. Dr. Poon, please, can you also share with the audience some more on your background?
Thank you for inviting me. I'm also very, very glad to be here. My patients call me Michelle because they are actually adults. I'm a consultant with the Department of Hematology, NUH, and my interest is in transplant and treatment of malignant disorders, especially lymphoma. So, as a transplant physician, I've seen firsthand all the sort of help and how important transplant is for our patients with malignant diseases. And so I'm actually also volunteering with the medical committee for BMDP because I've seen firsthand how important all these efforts are to help our patients. And thank you for inviting me also.
Thank you, Dr. Poon. And Dr. Poon, we'll start with you. If you can share what are some of the common blood diseases that you see among adults, and how are they diagnosed and treated?
Yeah, sure. So I've prepared some slides which maybe I can share with the people online as well. So because I do think that looking at the image is always easier for you all than actually sort of hearing me just speak. Okay. Okay. So types of blood diseases and clinical symptoms. So I thought I would just highlight, because of the interest of time, I highlighted a few malignant conditions that are commonly affect adult patients, and that's leukemia, myelodysplastic syndrome, and lymphoma. So first, I think leukemia is something that people hear a lot about, but what actually is leukemia? So, within the bone marrow, there's actually cells called stem cells, which are the baby cells that then grow up to form the adult cells, which are the white blood cells, the red blood cells, and the platelets. And basically, from the baby cells, they actually grow up to form the normal cells. But in patients with leukemia, for whatever reason, this growing up is actually affected. And as a result, there's a stopping of the maturation, and instead of having mature cells in the bone marrow, in patients with leukemia, they have immature cells in their bone marrow, and whole bone marrow is packed with immature cells, and eventually it affects the growth of the normal cells. And so you can see in this diagrammatic representation, a normal bone marrow has many different types of normal cells. In patients with leukemia, the whole bone marrow is actually packed with very immature cells. And you can see on this diagram as well that as the abnormal cells grow, the normal cells get less and less within the bloodstream, and instead the bloodstream is filled with these immature cells as well. So the types of leukemias that we deal with include acute as well as chronic leukemias, and myeloid or lymphoid just means which lineage the cells grow into, a bit like males and females, so myeloid, lymphoid. Okay, and then acute are more aggressive and the chronic leukemias are more slow growing. And so what are the manifestations of leukemia? Obviously, when the bone marrow is packed with immature cells, the normal cells do not grow up well, and so patients will have low blood counts and the complications. And these could include, for example, if the white blood cells are low, the patients could have a high risk of infection. If the red cells are low, they could feel giddy, because the red cells are like the engine or the oil for the body. And without red cells, patients have breathlessness when they exert, they lack energy, they feel fatigue. And last but not least, low platelets. Platelets help our blood to clot. So when platelets are low, patients may have bleeding complications. In addition, as the leukemia progresses, eventually the aggressive cells within the bone marrow then comes out into the bloodstream. And that what happens is that there's a condition called hyperleucocytosis. And in hyperleucocytosis, if you think about it, it's like the PIE being jammed with cars. So the whole blood vessels are jam-packed with abnormal cells. And you can see this picture here where the blood vessels are filled with the abnormal cells. And if that happens in the lung, you get a white, this is a scan of a patient's lung. It's a CT scan where they lie flat, and images are done of the chest. And you can see that unlike normal lung, which is black, these lungs are white, and that's due to the abnormal cells infiltrating the lung. So patients with this condition feel breathless. In addition, if the blood vessels and the abnormal cells pack up the blood vessels in the brain, it can cause bleeding or even strokes. And that's another complication that is concerning. So next we go on to myelodysplastic syndrome. I highlighted myelodysplastic syndrome because it is quite rare, but it does cause, if it happens, it can only be cured by a bone marrow transplantation. And we have cured many patients, young patients, with a bone marrow transplantation with this condition. And myelodysplastic syndrome is basically a disease which occurs when the bone marrow doesn't function and it produces abnormal cells. So I like to tell my students that a myelodysplastic syndrome is a bit like a chocolate factory then producing ice cream. So that's clearly abnormal. Okay, and if you can see, I just wanted to show what we say, when we say the cells are funny. So the cells here, you can see this is a normal cell. And if you look at these cells, they look funny compared to this, right? Either they have like 1 or 2 circles rather than 3, the nuclei of the cell. So these are abnormal cells, and that's what happens in myelodysplastic syndrome, where the cells are abnormal and they do not function well. And so what happens then is, again, similarly to leukemia, because these cells do not function well, patients get all the complications: low white cell infection, low red cells, giddiness and all, low platelets, bleeding issues. And eventually, because the cells are so funny and they do not grow well, eventually they keep changing and they may eventually become acute leukemia. So the aim of treatment is to try and treat them before they turn into an acute leukemia. Last but not least is lymphoma, and basically this is slightly different from leukemia and myelodysplastic syndrome. So, but before, it's harder to explain lymphoma than leukemias to patients because, people can visualize the blood vessel and all that, but lymphomas is always harder to visualize. And in lymphoma, before we talk about lymphoma, we need to know what's a lymphatic system. So the lymphatic system is basically the body's system that helps to protect patients against infection and disease, or we call it the germ fighting network. And as part of the lymphatic system, there are structures called lymph nodes, which are found in the neck, in the armpit, and in the groin region, as well as an organ called the spleen and the tonsils in the throat area. And white blood cells or the soldiers are present within these germ-fighting structures. So in lymphoma, what happens is that these germ-fighting structures, these soldiers turn abnormal and become cancerous. And as a result, there may be swelling of the lymph nodes, the tonsils, or the spleen. Okay, and lymphomas, the two main types are Hodgkin's and non-Hodgkin's lymphoma. And the difference between the two actually, it differs based on the clinical appearance, the histological appearance, meaning when they look under the microscope in Hodgkin's, you see these cells, these funny cells, which are not seen in non-Hodgkin's lymphoma. And basically, these lymphomas also have different clinical presentation, different prognosis. So if you look, actually, leukemias and myelodysplastic syndromes are actually less common. And in fact, lymphomas are actually the most common, the top 5, top 10 actually, cancers for both males and females in Singapore, whereas leukemias and myelodysplastic syndrome are actually less common. And how do patients present? For lymphoma, they normally present either with a lump, a swelling of the germ-fighting structures that have turned cancerous, either in the armpit, in the groin, or in the neck, or they may have fever, sweating, weight loss, and other or itching symptoms like that. So that's something that lymphoma presents with. In addition, if the lumps or the germ-fighting structures that turn abnormal presses on vital structures like the spinal cord, patients could have what we call cord compression, where they may have paralysis or risk of paralysis due to the compression of the spinal cord by a lump or a tumor. And sometimes the lump can be in the chest region where it presses on the blood vessel, and because the blood flow from the brain down to the heart is compromised, there is swelling and facial swelling and redness, and patients feel very breathless. So how do we then make a diagnosis of these blood conditions? I think basically there are a few ways of making a diagnosis. Firstly, doing a bone marrow aspiration and biopsy, which means putting a small needle into the patient's hip to collect the bone specimen and to look at the blood cells within the bone marrow. And this is a diagrammatic representation. So this is the small piece of bone that we take out from the bone marrow biopsy. We put, and this is actually it's melted down and is cut through, and this is then stained, and you can look at it under the microscope. In addition, some of the blood cells are also put into a media to grow so that you can look at the genetic abnormalities within the cells. For lymphoma, the diagnosis comes also from a tissue diagnosis, but in this case, the tissue that is taken out is not the bone marrow, but the lymph node. And this is a diagrammatic representation of an operation to remove a lymph node swelling. And this is then looked under the microscope to identify what the diagnosis is, and if it's lymphoma, whether it's Hodgkin's or non-Hodgkin's lymphoma. So last but not least, we talk about how these cancers are treated, these blood disorders are treated. And basically, just to summarize very briefly, and we'll be happy to discuss this during the session. Acute leukemia, the treatment is actually chemotherapy. For patients with high risk, transplantation is actually required. For chronic leukemia, the treatment is either chemotherapy or targeted therapy. So I just wanted to show you some figures. This is data from the registries that show that if patients have leukemia, be it favorable or unfavorable leukemia based on genetic stratification, if you do chemotherapy alone, the risk of relapse is higher compared to if you do a transplant. So you can see, for example, if you have bad risk genetics and you just do chemo alone, almost certainly more than 90% of the time, the cancer will come back. Whereas with a transplant, we can help to reduce that relapse risk by 40% to 50% and give the patients a better chance for cure. And therefore, transplantation is actually very important in this setting. Targeted therapy has also been used to treat blood malignancies. For example, one of the chronic leukemias is chronic myeloid leukemia, and with research has identified the genetic abnormality, and there has been a development of a drug which actually targets specifically the abnormal genetics and leads to stopping of the abnormal downstream signaling, leading to resolution of the complications of this condition. And last but not least, Myelodysplastic Syndrome. The treatment is actually just basically supportive because your factory is abnormal. You can't make it better. The only way is to get rid of all the machinery and restart the whole factory. And that's basically an allogenic transplant, meaning transplant from somebody else to yourself. And until then, it's mainly supportive, giving blood products. For lymphoma, the treatment is chemotherapy, immunotherapy, meaning antibody therapy, and radiotherapy as well. And how have we fared over the years in improving outcomes? So I just wanted to show you. So this is data from our center that looked at the results of leukemia treatment. So you can see that this is, in the past, for young adults, we used to use a protocol called HyperCVAD, and the 3-year overall survival was about 40%. But in time now, with using of the pediatric, working closely with our pediatric colleague, we've started using the pediatric protocol called the MASPOR protocol, and you can see there's a significant improvement in outcomes over the years. So now with MASPOR, we can achieve cure in about 80% of patients. And similarly, leukemia-free survival, meaning they are alive and without leukemia, in nearly 75% of patients. And that's a significant improvement from 38%, say maybe about 10 years ago when I first started my training. So I think the outcomes are getting better. And in addition, and of course, these results includes the use of transplantation when appropriate. For lymphoma, you can see that actually the outcomes are also very promising. This is data for primary mediastinal B-cell lymphoma, a subtype of lymphoma for patients treated in Singapore, both NUH as well as NCC and SGH. And this is combined data from our centers that show that we can achieve cures of up to 80 to 90%. So I think the future is promising. I think there are a lot of new treatments that are coming out, and we are hopeful that we can continue to improve on our outcomes and help our patients. Thank you.
Thank you so much, Dr. Poon. And Dr. Poon, a quick question: what's the oldest patient that you have treated?
For myself, the oldest patient I've treated to date would be 97 years old.
Wow. Cool. Thank you, Dr. Poon.
Thank you.
Dr. Frances, can you please share what are some common blood diseases that you see affecting young children? Are they similar to those in adults?
Sorry, can you repeat that again?
Yes, sorry, Dr. Frances. Can you please share what are some common blood diseases that you see affecting young children, and are they similar to those in adults?
Okay, so just briefly, I think in pediatrics, we do see some of the conditions that Dr. Michelle mentioned earlier. So childhood ALL, acute lymphoblastic leukemia, is the most common childhood cancer, making up about 80% of the types of childhood blood diseases that we see, malignant blood diseases. The other types of childhood diseases that are more unique to pediatrics would be really the non-malignant conditions, such as thalassemia, hemophilia, and also bone marrow failure syndromes like aplastic anemia. So I don't know if it's better if we share the slides where I've described some of this. Yeah.
Yes, please, Dr. Frances. I think that'd be great.
Sorry, just a minute. I thought it would be shared from that screen. No. Can Angela pull it up from?
Dr. Yeap, you will be sharing from your own screen.
Okay. Is it possible? Because I have it on my other computer.
Okay, let's see if we can, just while we're pulling that up.
Okay.
Maybe Dr. Frances, if you could also just share as well, what's the youngest patient you've treated? And also, how do you determine if a patient is a pediatric or an adult?
Okay, so the youngest patient we've treated, well, probably for blood as well as non-blood cancers or even immunodeficiencies, maybe about 3 months of age that they present. And that's probably the youngest 2 to 3 months of age that I've seen. Most of the patients that we treat, generally our cutoff is about 16 to 17 years of age. Subsequently, they will be transferred to the adult service. But because we do keep many of our long-term survivors who may relapse, who may develop secondary cancers, we have up to patients who are up to 23 to 24 years old who are still under the pediatric childhood service. Yeah.
Okay, thank you, Dr. Frances. And Dr. Frances, we've actually got the first question for you, directed for you. So the question is, hi, doctor. My first child has Thalassemia major. If I try for a second baby, what are the chances for my baby to be a match for my first child? And if they're a match, at what age can my second child donate his or her bone marrow to my first child?
Okay, so if I don't understand the question wrongly, there is a first child with thalassemia major, and we're asking about if there is a new baby. The chances of match, unfortunately, is probably less than 25% to have a fully 10 out of 10 HLA matched sibling donor. If the child is deemed that the new baby is going to be a full match, and we can actually test this in utero, then possibly cord blood can already be collected prior to the baby being born. But this again is an ethical question that needs to be discussed. And if we're talking about a matched sibling donor transplant subsequently, then as long as the child is Gilead competent and we deem that the child fully understands the procedure that they are going for and what it means to be a donor, then they can proceed if they are a fully matched 10 out of 10 donor.
Okay, thank you, Dr. Frances. Dr. Frances, we've actually got your slides ready now.
Okay.
So we'll just pull those up, and then if you can go through those. Thank you.
Okay. All right. So again, just to introduce myself, I'm Dr. Frances, and I'm a pediatrician as well as a pediatric oncologist in NUH. I will request remote control. Is that okay?
Yep, that's good.
Okay. Okay, so as I mentioned earlier, we see a range of childhood blood diseases, and I've really grouped them according to whether they are malignant, meaning cancerous, or non-malignant, which we otherwise term as benign. So malignant childhood cancers, blood cancers such as acute leukemia, which is ALL, acute lymphoblastic leukemia, and acute myeloid leukemia. I think that's just before this, Dr. Michelle shared what are the different cell lines that are involved for the different 2 types of leukemias. We do see some children also developing chronic leukemia, chronic myelocytic leukemia, and they are also, as Dr. Michelle shared, chemotherapy now is the first line, and those that don't respond can also be considered for a bone marrow transplant. The second most common malignant childhood blood disease would be lymphoma, followed by myelodysplasia, which is much rarer in the pediatric age group, and myelodysplasia in itself can transform into acute myeloid leukemia. We also see a lot of non-malignant conditions. This doesn't mean that it's actually easier to treat them or they don't require a stem cell transplant. So for some of the non-malignant conditions like thalassemia, as well as bone marrow failure syndromes, stem cell transplant is actually the only curative option. So when we think about non-malignant blood diseases, we can think about them as the 3 different cell lines that are involved in the bone marrow. You have the red cell line, which causes anemia if there's underproduction. If there is a platelet, which is the cell that helps in the clotting, in the bleeding, stopping the bleeding, then there will be thrombocytopenia. If the white cell lineage again is affected, not causing leukemias, but there's an underproduction, then these patients are what we call having cyclical neutropenia, or even if they are born with it and they present very early, they have severe congenital neutropenia. And if all the cell lines are involved and we do have children presenting from a very young age with bone marrow failure, which can be inherited or it can be acquired. So the bone marrow failure syndromes are a big group that we see uniquely in children, and also drug-induced bone marrow failure, but that is self-resolving. So this is a slide that shows the cancer incidence in Singapore as supported by the Singapore Children's Cancer Registry. So over the last 20, 30 years, we actually see a doubling of childhood cancer incidence, probably as we are more aware now as well. And a part of it may be due to the environment that we are in, changes in lifestyle, etc. Thankfully, this is looking at childhood leukemia, and thankfully for children, they are probably hardier, their organs are more pristine, they tolerate chemotherapy better, and this is based on, again, the MASPOR, which is the Malaysian-Singapore trial, which was first designed by a pediatric oncologist practicing in NUH, Prof. Allen, and we see childhood survivors with ALL surviving 85 to 90%, and this is from the 2010 data. So I would say much better than adults, and we have an easier job than our adult colleagues because they are a lot more frail, and children are a lot more hardy. Even with very aggressive chemotherapy, they bounce back within the next 24 hours. So the diagnosis of leukemia, as Dr. Michelle had already shared, really it requires a very good and detailed history. Usually with leukemia, because the bone marrow, the factory where the cells are produced, is not functioning, there will be signs and symptoms. The child may present with what we call pallor. They look a bit pale. They cannot finish their usual PE exercise because they are very tired. They get more breathless. Parents will say that the child looks like they have more bruising, bleeding, even more frequent nose bleeding, gum bleeding will be brought to our attention. So then we will have to take a very good detailed do a full physical examination, looking at the child from head to toe, looking for, again, the signs of all the 3 cell lines that may be involved. The child will be pale. We look for lymph nodes that could be in the neck, could be in the groin, could be in the armpits. We look for a large liver, a large spleen, which is very commonly seen in all the leukemias and lymphomas. And then we also look for leukemia that could be hiding in specific sanctuary sites like the testes in boys. And also, unfortunately, if it involves the CNS, which is the brain, then they may have some neurological signs as well. We will always then proceed with a full blood count, looking again at all the cell line involved, to look under the microscope, which can be done almost instantly for what we call a peripheral blood film, to look for blasts. And then if there is indeed a suspicion of a leukemia or a lymphoma, we will always send for a bone marrow examination to look under the microscope, as Dr. Michelle showed the slide of how we do take out a specimen of the bone, to look under the microscope for any abnormalities, any funny looking cells. And that was probably the most crude way of looking for lymphoma and leukemia. And now we have more sophisticated tests to look at genetics, to look at leukemia at a deeper level, so that it's more sensitive. And before we start on any chemotherapy, the child has to be assessed. We will have to do tests like an X-ray to look at the heart function and make sure there's no other infection that would prohibit us from administering chemotherapy. Okay, so the treatment of childhood blood cancer, like adult blood cancer, I think the first line is still chemotherapy. And we already achieved very good results in a majority of our leukemias. I would say about 70% of 70 to 80% of childhood leukemias can be cured by chemotherapy alone. However, there is this 10 to 20% group that requires a stem cell transplant. So other than chemotherapy, we also have immunotherapy, which is what we call targeted therapy. Chemotherapy it's like a blind machine gun shooting everything in sight. Even normal cells get injured, whereas immunotherapy is more specific, is more targeted. Then we talk about cellular therapy before stem cell transplant. So in NUH, we do a lot of cellular therapy as well. We use NK cells, we use CAR T cells that are probably as effective in bridging, at least bridging the patient towards a stem cell transplant. And finally, we talk about stem cell transplant as being the final frontier or the last step towards curing a patient, whereby we are actually trying to harness the donor's immune system, put it into a patient to control the leukemia lifelong. Okay, so I'll just end off, I think, with a slide on bone marrow transplant. So I'm very glad that over the last 15, 20 years, when my boss, my predecessor started, we used a lot more cord blood transplant. We did a lot more cord blood. We did a lot more matched sibling donor, matched unrelated donor. But in the last 10 years in NUH, I think we've really developed the platform of haploidentical stem cell donors, whereby any parent of a child can be a donor to their child as long as they are fit and able to donate. Yeah. Okay, thank you. And oh yeah, so that's a little British boy who I think was on the news quite a lot recently. So he came over from the UK to seek cellular therapy in NUH. He received cellular therapy in the form of CAR T cells and then was given a stem cell transplant. And he's now back in the UK for the last 3 months, and he still remains in remission. Oh, I'm happy to take any questions.
Thank you, Dr. Frances. Thank you. Okay, so just a quick question for Dr. Michelle. So do we see non-malignant blood diseases among adults as well?
Yes, we do, and I'm sorry that I didn't have a chance to go through that because of the time constraints. I think conditions like aplastic anemia, which Dr. Frances mentioned, where the factory is basically not functioning, is empty, we see that as well. Thalassemias, we do. So a lot of the thalassemia patients that we see have graduated from the, so to speak, from the pediatric side, and the adult hematologists will take over their care. So I think these are the more sort of common sort of blood disorders that adults will see. And of course, there's also multiple myeloma, which is a more of a older patient's disease, where transplantation, allogenic transplantation from another donor is not usually used. Yeah.
Okay. Thank you, Dr. Michelle. Right, so we'll now go on. So we've got some audience questions that have come in, some that have come in whilst we've been on air, and some that come in earlier. So let me just pull those up. So the first one we have in is for Dr. Michelle. So how many non-Hodgkin's T-cell lymphoma cases on average in Singapore per year? And how many of those get a transplant? Allogenic always.
Okay, so I don't have the absolute numbers, but looking at basically our center alone, I would say that we see about for T-cell lymphomas, they are much less than the B-cell type non-Hodgkin's lymphoma. So maybe on average about 20 or about 10% of what you see for B-cells. So maybe about 20, 30 per year in our center alone. So if you multiply that, nationwide, probably about maybe 100+ cases a year. It's not that common. Amongst these patients, a majority of them may end up getting just chemotherapy alone or an autologous transplant, meaning transplantation using their own cells. So I would say, if you ask me how many of those might need an allogenic transplant, maybe about 20–30% of them, and those who don't get a transplant are either cured by the treatment, or they may be too old or too unwell to get a transplant.
Thanks, Dr. Michelle. Dr. Frances, we've got a question coming for you. In the 2.5-year-old child with thalassemia major, the child's white blood cell count is 14,500 and sometimes have fevers. Is that okay? Is it also okay for the child to also be given steroids whilst having blood transfusions?
Firstly, in thalassemia, I don't expect the white cell count to be high. I don't expect the white cells to be affected. And a child with thalassemia should not have increased risk of infections. It may be that this is a 2.5-year-old normal immunity, and we do see that 2.5 to 5 years old, they do get frequent viral infections. That may be every other month they get some 2 to 3 days of fever, and that's very normal. They should resolve on their own. They don't need antibiotics. The second thing is I'm not sure why this child with thalassemia is requiring steroids, because the steroids have no role in the treatment of a thalassemia patient. Yeah. If that helps to clarify.
Okay.
Yeah.
Thank you, Dr. Frances. A question also, maybe this one it's targeted to both doctors, but maybe Dr. Michelle. The audience members said they're anemic, but their red blood cell production is normal. Is it advisable for them to donate bone marrow should they be a match?
Yeah, normally for patients who are anemic, I think we would like to know the reason why they're anemic. So meaning why their hemoglobin within the red cells are actually low. And so depending on how low the blood counts are and how symptomatic and what the cause is, we can then decide whether is it safe for them to donate.
Thank you.
Sorry, just a quick comment. I think I looked at the question about the thalassemia, and I think I realized why. It's because the steroids given during transfusion is probably to reduce a transfusion-related reaction. It's the low-dose hydrocortisone that we give in patients who have had a previous reaction towards a blood product, and that is required subsequent transfusions to prevent a reaction, and that's fine. Yeah.
Okay, thank you. A question that came in earlier, and probably if you can take this one, Dr. Frances. So, are there any blood diseases that are hereditary?
Blood diseases that are hereditary. So yes, as I mentioned earlier, so thalassemias are again a very one of the more common blood diseases that are hereditary. Hemophilia again is also hereditary. Severe congenital neutropenia, again, there are mutations that can be inherited. So these are a few that can be inherited. Yeah.
Okay. Thank you. Okay. And another question coming from the audience. What is the success rate in Singapore for a child bone marrow transplant? So
specifically for a child? Okay, so it really depends on the underlying condition, whether it's a ALL, like acute lymphoblastic leukemia, acute myeloid leukemia, and we look very closely at the comorbidity index, meaning how the child is before they enter transplant, whether they've had a previous transplant, whether they come in with already a liver that is not functioning so well, or they come in with a lot of infections. That really prognosticates the child a lot. But I would say on average, a bone marrow transplant would at least ensure about a 60 to 80% risk of long-term overall relapse-free survival. Yes.
Thank you. Thanks, Dr. Frances. And Dr. Michelle, another question's come in. Being parents of 2 kids, are there any diets we can follow to avoid blood-related diseases? Any do's and don'ts as a precaution?
Yeah, so actually, diet is a question that we get asked a lot, and honestly, there isn't really any diet per se that has been clearly shown to prevent blood cancers. We do still recommend that people eat a balanced diet, but I don't think there's been any clear correlation that a diet is, changing your diet will help to prevent a blood problem, a blood cancer or a blood problem. I hope that answers.
Thank you, Dr. Michelle. Okay, so I now have some specific questions around bone marrow transplants and bone marrow matches. So how is finding a bone marrow match different from finding a blood type match? And maybe Dr. Michelle, if you want to take that one.
Sure. So when we talk about blood group matches, so blood groups, basically there are very few blood groups. So your blood group can be A, B blood group, AB or O. So there's only 4 types of blood groups. For bone marrow transplantation, you need to match the genetics, or what we call the human leukocyte antigen. So those are like 10 numbers to match. So, and that's a lot harder to find, as you can probably imagine. So between finding a blood group match versus finding a bone marrow match, I think it's quite, the blood group match would be not too difficult to find. And that's why it's easy enough if somebody needs a blood transfusion to get blood. But for a bone marrow transplantation, it would be quite challenging outside of your family. And that's why big registries are actually needed. So, and for a sibling, the chances of a match would be about 1 in 4. For non-sibling, the chances would be much slimmer.
Thank you.
Thank you.
And Dr. Frances, how do you decide when a patient needs a bone marrow transplant?
Yeah, so I think the transplant indication usually would depend on, number one, the disease again. So as we mentioned, there are about 10 to 20% of, for example, childhood leukemia that is incurable, or what we call chemo-refractory. They just do not respond to chemotherapy. We cannot get them into a remission, and that's a clear indication for a stem cell transplant. The other types of indications would be, for example, a thalassemia major, where there is no curative option other than possibly now there is some gene therapy in some of the other countries in Europe that's been tried, but generally there is no curative therapy other than changing the stem cell of the patient. So then a stem cell transplant again becomes a clear indication. So bone marrow failure again is another clear indication that stem cell transplant is needed. Yeah.
Okay, thank you, Dr. Frances. Okay, so BMDP has over 109,000 donors, but based on an ethnic study done by BMDP, a local patient has various probability of finding a matching donor depending on their ethnicity, and all of them has less than 50% chance of finding a match. Why is the probability of finding a matching donor low? Maybe if we start with Dr. Michelle.
Yeah, so the reason is that I think it depends on a few factors. So one factor would obviously be within the registry, the ethnicity within the registry, because people of the similar ethnic groups will tend to have a more likely chance of finding a match within their own ethnic group, and that relates again to the genetic makeup of the patients. I think secondly, also depending on the ethnicity, what we call the heterogeneity of the genetic makeup may differ. So Chinese, for example, have a more sort of homogeneous kind of makeup, whereas for other ethnicity, it might be a bit more heterogeneous. And if it's more heterogeneous, then it's harder to find a match, and therefore, again, it goes back to, if the chances are slimmer, you need a bigger registry to have a better chance of finding a donor.
Okay, thank you, Dr. Michelle. And Dr. Frances, we've actually had one more question coming from the audience, directed to you. Can siblings also be considered for haploidentical transplants? And how do the outcomes compare to unrelated donor transplants?
So yes, siblings can definitely be considered for haploidentical stem cell transplant. Currently, I think it differs from center to center, but we have limited the cutoff age to 17 years and above, that they can be a haploidentical donor. So not a full match, but a half match donor. I guess it's because it's a newer type of transplant. There may be more risk involved conventionally, and so in terms of the donor well-being and the donor health, they have to fully understand what being a haploidentical donor means. So our age limit, the minimum age is 17 at the moment. In terms of haploidentical transplants, I think there was a lot of fear for complications like rejection, as well as graft versus host disease, because the HLA, as Dr. Michelle was talking about just now, in a haplo is a half match. So as you can imagine, it's putting in a very different donor repertoire into another host, and so you expect there to be a fight between donor and host, and you would have imagined that there is a lot of graft versus host disease that may occur, which is a very dreaded complication in transplant. But as we improve in terms of being able to select out the cells that we want, where we can deplete out the cells that causes a GVHD. We have used haploidentical stem cell transplant in almost 100 patients now in NUH in pediatrics. And in adults, I think they use a lot of post-transplant cyclophosphamide as well, where it's a much cheaper option and you do not need to manipulate the cells as much. Yeah. And I think in terms of results, I think recently they also showed in various studies that it is actually comparable. And in fact, the relapse risk in using a haplo donor may actually be lower than that of a matched sibling donor or even a cord blood transplant.
Thank you, Dr. Frances. Dr. Michelle, we've had another question come in for you. Has any scientific research successes helped with blood diseases in any way, such as detection, finding a match, or in the method of curing?
Yeah, I mean, I think that's a very interesting question. And actually, a lot of the advances we have to date are precisely because of all the research that has been done in the field. So as an example, I think you saw the picture that I showed of chronic myeloid leukemia and the targeted therapy. And that's one of the sort of landmark successes in the treatment of blood disorders. So prior to that, patients with that condition, chronic myeloid leukemia, was basically, they had to have a transplant or they would die. So, but with that medication, transplantation is no longer required for the treatment of chronic myeloid leukemia, and patients are completely well just by taking a tablet a day. So it's a phenomenal success. So apart from that, other sort of research findings that help to improve outcomes include obviously CAR T-cell therapy that I think Dr. Frances mentioned, where people have learned that the immune system is there to help to fight cancer, and if you can use the power of the immune system to kill cancer, you can actually make great strides ahead. And there are many of these examples, and I think that's the important thing, that the fact that patients are willing to be enrolled into these trials that look at novel therapies and therefore allow for continued development in the field and to development of new treatment that can help patients. So yes, definitely, I think research has definitely improved the diagnosis, the treatment of blood disorders tremendously.
Thank you. Thank you, Dr. Michelle. And last question to both of you. Do you have any words to future donors if they become a match? Maybe Dr. Frances, we'll start with you.
Well, I think it's a great thing to be able to be a match donor for someone who is really in need of a stem cell transplant. And I definitely encourage anyone who is fit, young, and able to donate, to go forward and try to be a match. And if you are really a match, it is a wonderful opportunity to be able to give someone else a second chance at life. Yeah.
Well, I completely agree with Francis. I think the chances of a match are not that. It's very hard to find unrelated donor, and you know, the chance to save someone's life, to help someone, I think it's really an amazing opportunity.
Cool. Thank you, Dr. Frances and Dr. Michelle, for sharing your knowledge and personal experiences of treating both adults and children's blood diseases. I think the audience and myself have learned a lot over the last hour. You know, blood diseases like leukemias and lymphomas can affect anyone, young or old. And for some, bone marrow transplant may be their last treatment option. So this is where everyone can play their parts and help take us one step closer to finding a match for patients affected by blood disease by registering to be a donor. The more donors on the register, the more chance patients will have. And I think, you know, signing up could not be easier. And we're about to just show a couple of slides on that. So as long as you're between 18 and 49, head over to the BMD website, and the URL is linked on here as well. Complete the form and you will receive your swab kit within 3 days. Simply take the cheek swab and mail back your sample. Cool. Please look out for and sign up to the next exciting Match for Life fitness sessions and Marrow 101 sessions. And they're coming up on the screens now as well. The next sessions. There's the fitness sessions listed, and also the Marrow 101 sessions there as well. Yeah, so please do register for those. And lastly, I think thank you once again to Dr. Frances and Dr. Michelle, and thank you to the audience for joining tonight's webinar. And my last message is be a bone marrow donor and choose to save a life. Thank you and good night.
Thank you.